All right, hello physiology students. I hope you're all doing well. Thanks for all your work. You guys are doing a great job with the lab activities. Just a reminder that for this lab, you will be doing a lung volume lab. We'll be back in the PhysioX exercises. You'll have exercise 7 to do and just activities 1 and 2. And then you'll have a lung volumes calculations worksheet that is a little bit longer. And then we'll have a lung volume quiz like usual in a week. If you have any questions about that, let me know, but we'll be looking at lung volume itself. Some of you have noticed that we're going through your lab book or trying to. So as you're working through this lab, if you need any extra information, you can always look to this lung volume lab, and it starts on page 114 of your lab manuals. So we'll be talking about pulmonary ventilation, which is commonly referred to as breathing. It's the process of air flowing into your lungs during inhalation or as inspiration and out of the lungs during exhalation. Air does this, it flows in and out because of pressure differences between the atmosphere and the gases inside the lungs. And we'll see how those pressure differences are made. Pressure volume changes occur during inhalation and exhalation. And we'll look at inhalation first. During inhalation, your lung volume expands as a result of the contraction of your diaphragm and intercostal muscles. So when your diaphragm and intercostal muscles contract, that actually expands your thoracic cavity. When it does that, it increases the volume and the pressure decreases. So Boyle's law is an inverse relationship between pressure and volume. That just means that when volume goes up, pressure goes down. So because pressure decreases due to the increase in volume or capacity in your thoracic cavity, the decrease in pressure causes air to rush into your lungs. So that's how you get this kind of deep rush in of air into your lungs during inhalation. During exhalation, the opposite happens. So your diaphragm relaxes, moving back into its dome shape that it normally is in, which will bring it higher into the thoracic cavity. So your thoracic cavity will become smaller. This increases the pressure within the thoracic cavity because it's becoming smaller. So air will rush out of the lungs due to the pressure difference because it'll rush to a place where there's less pressure. So that's what happens during exhalation. Factors affecting this breathing or ventilation rate. Surface tension of alveolar fluid. Alveolar fluid is called surfactant, and it helps to reinflate your lungs after exhalation. So after exhalation, your thoracic cavity is decreasing, and the surfactant helps to keep your alveoli open all the time. Some babies who are born prematurely, the biggest thing that doctors are worried about with premature infants is that their lungs aren't fully developed, and that's because their cells in your lungs haven't created enough surfactant to keep their alveoli open. Because this surfactant is extremely important for keeping the alveoli open at all times. Alveoli are the little structures at the ends of the bronchioles. They look like little clusters of grapes. And if they collapse, then you can't have the gas exchange that occurs between the air and your blood. Lung compliance is the ability of the lungs and the pleural cavity to expand and contract based on changes in pressure. So that's just the ability of your lungs muscles to expand and contract. And then another factor which affects ventilation is what we call airway resistance or obstruction could be in here. And this could be caused from some sort of disorder. It refers to resistance in the respiratory tract due to airflow. So this is a spirographic tracing. Spirometry is the most common test to measure pulmonary function, and it's used to diagnose obstructive disorders such as asthma or emphysema, and restrictive disorders such as pulmonary fibrosis. So if we were in lab, we would have you guys blow through this device, and we would measure the amounts of air that are going into and out of your body. So by doing that, we would get what we call a spirographic tracing. And this is commonly what it looks at. So what the blue line refers to is air going into and out of your lungs. TV stands for tidal volume, and that's the volume of inhaled or exhaled air during a normal quiet respiration. There's average amounts of tidal volume. It's about 600 milliliters in males and 500 milliliters in females. So tidal volume is normal breathing. The IRV stands for inspiratory reserve volume, and this is the volume of air that can be inhaled after a normal tidal inhalation. So you guys know you can normally breathe and then you could take a deep breath, and that would be your inspiratory reserve volume. You also have an expiratory reserve volume, and that means normal breathing, but you push out all the air that's left. Residual volume, RV, is the volume of air that remains in the lungs after maximal exhalation. It cannot be measured directly, but it can be calculated as 25% of the vital capacity, and we'll talk about what that is in females, and about 33% of vital capacity in males. We always have between 1 and 3 liters, depending on our gender, of reserve volume or residual volume of air in our lungs at all times. So vital capacity then, VC, the vital capacity just stands for your inspiratory reserve volume and your expiratory reserve volume. Whenever you see a capacity, the capacity stands for some sort of calculation that you can get by adding other volumes together. Total lung capacity is where your vital capacity plus your residual volume. Functional residual capacity, FRC, I'm just going to go on to the next one, is the calculation of end of ERV, expiratory reserve volume, plus RV. And you can see other pulmonary capacity calculations on page 115 of your lab book as well. But again, this is just a graph showing basically normal breathing, ventilation, and how much air is going into and out of your lungs. This is important to measure things like obstructive and restrictive disorders in people. Again, an obstructive disorder is like asthma or emphysema, where your airways are much more narrow, so they would be obstructed, and you would get lower volumes for some of these calculations. And then a restrictive disorder, such as pulmonary fibrosis, that would have to do with extra tissue buildup. So fibrosis means there's extra fibrosis or fibers built up in your lungs, and that would be some sort of restrictive disorder. Excuse me, I have extremely bad allergies. I'm not sick, but the allergies are just really bad right now. So this is what your pulmonary function tests might look like with a common disorder, whether it could be obstructive or restricted. And this is just showing the volume of airflow over time. And normally, this is what it would normally look like, whether it's the flow is inspiration and expiration is shown above and below the graph. And then the volume is kind of shown in the gray area over a period of time. In obstructive disorder, it shows you how the volume of airflow is greatly decreased. So if something is obstructing your airways, such as in asthma or emphysema, you're just not getting enough airflow into your lungs. Why is it bad if your lungs are obstructed? If your trachea, bronchioles are obstructed from asthma, emphysema, you can see here your normal blood flow or your normal airflow is extremely low. And that affects everything in your body because you're not getting the oxygen needed to your tissues to perform their functions. In restricted common disorder, you can see how the airflow is again greatly decreased, but it's much smaller over time. So with obstructive disorder, over the course of time, you can still get some air in and out. But if something's restricted, that means it could be completely blocked and you can only get so much air in. Or you could have some sort of mixed disorder as shown in there. The respiratory minute volume, also known as minute ventilation or minute volume, is the volume of gas inhaled or exhaled from a person's lung per minute. It's an important parameter in respiratory medicine due to its relationship with blood carbon dioxide levels. So this is respiratory minute volume, and you'll see this as you work through your worksheet. And then we get to alveolar ventilation rate. And this is just talking about breaths per minute and alveolar ventilation. Normal respiratory rate is about 12 to 15 breaths per minute. So in 1 minute, you'll breathe in and out. So one breath is one inhalation and one exhalation. And 12 to 15 is the normal or average. The alveolar ventilation rate is calculated by multiplying that respiratory rate, so your normal in and out in 1 minute, times the volume. And then the alveolar ventilation rate will get a rate as per minute or milliliters per minute. FEV1 is the amount of air you can force from your lungs in 1 second. So we would measure this if we were in lab, and you'll do this probably in your lab activities. It's measured during the spirometry test. It's a big test of pulmonary function because it involves forcefully breathing out into a mouthpiece connected to that spirometer machine. And it'll show if you have any sort of restrictive or obstructive disorder of getting the air out of your lungs. So this is FEV1. And that FEV, as you can probably figure out, will stand for forced exhalation. So this is the end of this PowerPoint. I know that was kind of short. You really have to learn a lot on your own with these labs, and I appreciate all your guys' work. Just keep it up. You guys are doing a great job. I've been really impressed with what I've seen so far. So thanks for your hard work. If you have any questions, let me know. Don't forget that for this lab, you have to do, I'm just going to go back to the first slide. You have to do PhysioX exercise 7, activities 1 and 2, and don't forget to do the lung volumes calculations worksheet. Hope you guys are all healthy and well. Take care.